So thank you for the introduction, and indeed it was a nice introduction to what we will be talking about, and also the fact that we are united here, the dietitians, the medical doctors, internal medicine, and all the backgrounds, and also in the room, all the people that are fighting the same fight against malnutrition. So thank you to Nestlé to bring us here together. Now, it's also very reasonable that we should consider that we have different feeding strategies. And different feeding strategies are available because our patients are different and they will need different strategies at different time points. And to optimize that use, one of the things we should think about is what is the challenge and what is the gastrointestinal function and dysfunction. And a GI tract is quite, a black box. You have CT scans of your lungs, you have a lot of meanings, but really look inside a stomach or an intestine and know what's going on with your GI tract during critical care and afterwards. It's not so easy, and it's not easy for us as clinicians to be able to guide your therapy. So let's go into that topic, and those are my disclaimers. So some questions. Yes, are we doing a good job? I think we can still improve, and we are many here to learn, but we have many more colleagues that can improve knowledge, and we can certainly do better. What about this GI dysfunction? And of course, we won't leave you here unhappy. We will also see some solutions that we have figured out and that many of you have also implemented or could do. Now, we have seen an evolution over time, and many more experienced intensivists are in the room here who tell me that over decades, the profile of our patients has changed dramatically. Even in my limited experience of 15 years of ICU, you could see the trauma patients, the construction workers, the young people going down in their prevalence in ICU. And we see an evolution in European countries to more older people, polymorbid, who have a lot of different situations together, different challenges, who are going in and out of hospital and ICU. So the profile of the patient has changed, and this is also something that the healthcare community should follow and is following, and this is what we're doing. So we have more and more people who will survive, but we have to follow them and take care that all our efforts in intensive care are not, unused and are not going to fail afterwards, so that we have this whole trajectory, and this is why we have this nice combination of people here today. Now, in intensive care, there has been huge amounts of, people combining energy, clinical nutrition, clinical studies, basic studies, but also technology evolving. And we have now, as a nutritional therapy, we have made large impact, and we have more, tools and ways of fine-tuning our treatment and making it real individual. So we can measure body composition, metabolic rate, we can keep track of what the patients are having as energy and protein, and we know the things that are important. So we are a little bit, coming to the same level as you have other treatments in ICU. So there has been a good evolution over time to guide us in our clinical decision-making. But still there are many challenges. And some years ago, we wondered in our institution in Brussels, are we doing a good job? Because, show me the data. You have to know where you are. So we wanted to know the adequacy of feeding in ICU and the same patients after ICU. So patients who stayed for more than 7 days in ICU. Some of the patients were also COVID patients. So we could see that in ICU, both on an energy and protein, we had some challenges, especially in the protein side. So we were in energy, depending if you're aiming at 20 kcal or 25, the energy was quite okay. I repeat, normally we are above 80, 85, but during Corona we had a large influx of patients, so it went down a little bit. The protein was a challenge, but when you look at the pinkish colors, which is in the ward, the same patients transitioning from ICU to the ward, they were the biggest challenge. And these were the dark numbers as we published it. It's the dark trial. And this is something that we can improve. This is something where you can work on, that you can measure again after your implementation of improvement programs, and you can see if you're actually doing a good thing. So for yourself also, please know what you're doing, get the numbers, get the information, and work on that. Now, when we get the data from this observational trial, we were also doing some sub-investigations because in the meantime, all this, more protein is better was being questioned. So we took the data and we went back and we saw what is going on. Well, in our limited one-center data, we could see that for energy, the U-shaped curve that was, historically and became very famous by the team of Pierre Singer, it's still valid. So the fact that underfeeding is not a good idea and the fact that overfeeding is not a good idea is still valid today. So this, the lower the better is not the signal that we get from our numbers. And also a very nice illustration by the team of Professor Van Zanten, where you can see that when you compare European and American guidelines, apparently also for protein, there would be this kind of optimum that is somewhere in the middle. So we are learning from the data. And we can see that, yes, we have a safe zone. We have a safe zone of nutritional therapy where we can actually have a mortality decrease or a survival benefit. So the power of nutrition is proven over and over again. Now, I won't go into detail because, of course, you know better, but very interesting here was that indeed there is not only the dosing, there's also the timing, and we know that we've been talking about it. But I get scared when I see clinical practice being performed by MDs, by medical doctors, intensivists, who are big specialists in something else, but not in nutrition, and they hear this thing of, oh, protein's no good anymore, let's go lower, and in the end, you're doing harm to your patient. Because in your data, you could see that when you are careful in those first days, but then you ramp up, and I think there's also some data from Professor Waele here in the room, that when the acute phase is done, you really have to step in, because then you have better survival, you have better cumulative survival when you are doing what you're supposed to do. So there's the timing issue is very important, and you don't have to, stay on the same lane for weeks and weeks. So careful early and then do what you have to do. Now, we were at the honor to contribute to one of the trials investigating this, let's say, high versus low. So what we were actually doing with many centers in the PRECISE trial is that we compared in enteral only, let's say, the American guidelines, and we achieved 1.9, to the European guidelines, and we achieved 1.2 at the same energy level, which is important. This is a protein trial with the same energy, and some other trials are not doing that, and that's quite confusing. Now, after this big and well-designed trial that was published in The Lancet, we discovered that it didn't prove to be very good to go to these very high levels, but there was, first of all, no mortality difference. So our patients have the same survival chances in both groups, which is, in this case, good news for America, where, they are going higher than we are going in Europe. Because if this would be, not the case, huge changes should have happened to our protocols all over the world. But we were reassured that we could continue the way we're doing. So no mortality difference. What is important to say is that, for example, in the female patients, the signal was not so strong. So the protein was more of benefit to the men than to the women. So this thing of looking for a magic number of grams of protein per kg per day, I think we agree that this is really not the good way to go. We should get away of that question, because it's also based on the weakest parameter in intensive care. How much do your patients weigh? Our 74, because in most of the time we don't know, and the nurses will put 74. So this is the weakest way of working, and we spend millions of euros investigating a magic number, which is a bad idea. Now, we were indeed already talking about this, and it has been shown by the chairman, that the opportunities probably once the patient has stabilized, and this is where we want to be, and this is where the opportunity for you is. And it's not only this post-acute critical illness, but the whole trajectory of care that we are talking about. Now, if we know that we have an opportunity, that we have the duty to step in after a few days and do what is supposed to do, get our patients to energy and protein target, whatever it takes, then we have to think about what are we going to do? How are we going to provide the energy, the protein, the micronutrients to our patient? And what about the gut? What about the GI tract? Now, I've been reading this paper a lot because it shows protein metabolism, and you know that there's an intake. You know that there's a conversion of free amino acids, and it's happening all the time. It's happening all the time because this transition and this makeover of proteins goes very quickly. And we know on the blue part that patients have a lot of reasons to lose all that muscle. You know, we know about the anabolic resistance, we know about procatabolic hormones, the disuse is there. So the sarcopenia is rapid and very quick and very devastating. So we know what's going on. But on the other hand, when you look at the pink thing, I was like, right, where is all the protein going? Where is all the protein going? And well, it's a little bit, you know, misleading, because if you do it in the right dimensions, this is what you get. The protein is used for the gut. The muscles are not so rapidly renewing. Somebody told me it takes 6 weeks to renew the muscles of your arm. But what about the gut? A gut is a very rapidly changing cell line. Think about patients on chemotherapy. What is the first thing that's going to suffer is the GI tract. But in the other way around, this is a cell line that needs to be rebuilt all the time, constantly. And this is why it uses up to 40% of all the protein that we are providing. Who thought that a kidney and a liver would use so much of the protein? So what we're actually doing is also healing the skin. You know that when you don't provide nutrients, skins and wounds are not going to heal. So I think that we could shift away a little bit from this focus on muscle mass and muscle strength and think about restoring the gut by feeding a patient. So this is quite eye-opening to realize that this is something we should focus on. And Saturday on the LLL intensive care, I was much inspired by Professor Hiesmeyer's talk, which is fabulous. And he explained that the energy is not used for muscles. The energy is not used for what we think it's used. It is used for cellular activity, for metabolic processes, to keep you alive. You have 1.5 seconds of stores. That's not a lot. So you can see that mitochondrial functioning, that, you know, pump and active pumping of ATP and so on. This is where the energy goes. So by energy, we are keeping the patient alive, and with the protein and the enteral feeding, we are restoring the gut and feeding the gut. So those are two different things. You want to keep your patient alive. It needs to be all the time and very rapid. And on the other hand, we want the body to rebuild and to recover. So those are different targets, and this is why we need different nutrients at different time points. Now, if we are motivated and we think, okay, we want to restore the gut, we want to keep the patient alive, and we have the opportunities, how are we going to decide what to do? Now, first of all, we need to realize that when you use artificial nutrition, you're just replacing normal food, because we are talking so much, you know, like what are the components, what should there be in the enteral, what are the components of the parenteral. We are replacing normal food, and this is what we're intending to do on a first layer. Of course, you have, you know, the field of micronutrition and so on, but in the first place, we are just keeping the patient alive by providing an alternative to normal food. Now, we have different patient profiles, and you have them too, and this makes that the decision on enteral or parenteral or a combination of both is not made by us and certainly not by experts doing research. The patient will be your guide. The patient will tell you, this is tolerated, this is not tolerated, and all of you who do bedside work, they know this. Of course, you're going to let your patient eat if he or she can eat, but when you calculate it, you know that eating most of the time is insufficient in ICU and after ICU. We had a poster on this Congress that actually said eating doesn't work after ICU, and it's true, it's been observed. Then you have patients that will go for enteral, and you have patients where you have, of course, immediate indications for intravenous feeding. If you see a patient in the room in intensive care, can you tell if the gut is functioning, yes or no? No, because you cannot see it. You cannot, you don't have good tests to know. But there is a possibility that inside the gut is not in a very good shape. Because when you go back and you go and see some research that's being done, for example, in mice models, when you have a septic situation, so when you do, puncture the cecum, as a surgeon, I get a little bit, itchy, like, ooh, why do you do that? It's such a nice organ. But when you puncture the cecum and your mice go into sepsis, you can stain the ileum, for example, and you can see the effect of a huge cytokine storm and a huge inflammatory reaction nutrition on the integrity of the gut. So what is happening in a patient has an impact on the gut, and of course, this will not be as efficient. So what is the efficiency of a gut in a critically ill patient or in a patient after critical illness who had a lot of influences? And all the other scary things they do in the research, for example, gastric lavage with E. coli, it is proven that in the septic patients or in the septic mice, it will also extravasate. So it will really move around and go to other organs. So we need to treat the gut with care. So how to know that bedside? How to know how the villi look of your patient? Well, this is a nice overview by, of course, a queen of gastrofunctional dysfunction. She left to the airport. I'm happy because, you know, I said I get too nervous when you're in the room. She provided, together with some colleagues, the judgment that clinical assessment is still very, very important to assess the GI function in intensive care. We don't have a marker that will tell you if the gut is functioning, yes or no. We would really like to have a CRP for nutrition and GI and so on. So you have to put things together, information, have this cloud of information, and we need better tools and biomarkers. So what to do in the meantime? There's been a lot of work by a lot of people. And here, for example, the results of a Delphi process where I was also involved, those are the things that we would, you know, classically use in our clinical practice to try and understand if our patient has a functioning gut, yes or no. But some of them are very imprecise. How about abdominal distension? Intra-abdominal pressure, you can measure it. What about pain in a patient who's in coma? Very difficult to know. So you can see all those things that we as clinicians will put them together and then make decisions, but it's a little bit a shot in the dark. You know, you're not really sure what you're doing. And then we have other barriers of adequate feeding. You have somatic functional disorders, and this becomes more obvious in a later trajectory, also out of ICU. There's so many reasons why patients couldn't eat or tolerate their nutrition, and we need to be aware of them. And this is my colleague, Professor Aerts, publishing and also having a poster here on all the reasons, the barriers of adequate feeding. Now, what to do? This is a first practical tip for you. If you're standing next to a patient, you can actually do this. You can make a nice checkpoint. You can make a nice Excel files. I love Excel files, you know. You just do it, and then you see, okay, where are we? What is the risk? Will there be a gastrointestinal dysfunction, yes or no? And you can actually also take clinical decisions based on this. So this is helping us. This is helping us in daily life when we stand next to a patient and we want to know what to do in the field of nutrition. Now, how to overcome those barriers once we identified them in a single patient? Well, my colleagues with a lot of experience in burns, they always told me, you have to be early with your enteral, really, really within hours after the accident, because otherwise, it won't work anymore. So if you can see, early enteral nutrition, for example, is apparently something that keeps the gut in a better place and makes it more positive to have a gastrointestinal function test. So if you can use it and keep it usable, you know. So there is this interaction between the enteral nutrition you're providing and the gut that is in a more homeostatic environment. But remember, you will probably maybe not always be able to totally fuel the patient, so a combination might be necessary. So exposure to enteral nutrition is very important, and this is why we always say that enteral nutrition will be the first choice. It has many advantages. It's like less technical than you know, the catheter care in ICU. It's still okay, but post-ICU, that's a risk. Many advantages, and also keeping the gut in a functional state. And then I really appreciate a paper that was written together with Paul Wischmeyer, because there are also a lot of myths, like you have said, that nurses believe, doctors believe, and they said when we had COVID, the patients came and then somebody said, oh, you cannot use enteral nutrition in prone position. We were, why not? It works. So we have to challenge that. Maybe it's true, maybe it's not, but we really have to see that we are acting on evidence and not a story that's been told in the corridor. So this is a nice paper to see that you really have, in a lot of challenging patients, also the opportunity to feed your patient. And this is why, when you look at big data, in critically ill patients, enteral nutrition is always and will probably be the first and the best choice. And with that, I thank you for your attention.